Hello. So, welcome to mini session number 4. This one, we will be going over patient preparation, breathing, collimation, marker placement, and um, shielding. Essentially, everything that couldn't be fit into another thing. So, let me go ahead and share the outline with you. First, we'll go over patient preparation, breathing instructions, marker placement, collimation, and shielding. And that is the outline that's on Canvas. Here is the PowerPoint. So, patient preparation. Make sure the patient is as comfortable as possible. Look, the table's very uncomfortable. Give them a pillow, stick a pillow underneath their knees. Remove all clothing and radio opaque items, including bras. Now, when you hear the word radio opaque, anything that is opaque, you cannot see through it. So if it's radio opaque, you cannot x-ray through it. This includes zippers and buttons and bras and cell phones and nipple rings and piercings and all kinds of other good stuff. We want to ensure we protect patient modesty by covering them with a sheet. Sometimes they can be cold if they're geriatric patients, et cetera, et cetera. Excuse me. So the biggest thing that we need to realize is that breathing instructions are very important for abdomens. Just the same way it was on chest x-rays, what we are doing is trying to prevent motion. And motion can result from voluntary movement and involuntary movement. So a voluntary movement is breathing. Involuntary movement is the peristaltic action of the bowel, and you can't stop that. So to try and prevent that from happening, it is encouraged to use the shortest exposure time possible. And we'll get more into this in a little bit. So, the second method to prevent voluntary motion is by providing careful breathing instructions. So, I should change that to say all. Well, no, I copied it out of the book, but whatever. Abdominal radiographs are taken on expiration. That means they blow all their air all the way out. You usually tell them to take in a deep breath, let it all the way out, and hold it. Don't breathe. So before making the exposure, if you ensure the patient that is following the directions and they know what to expect, and that sufficient time has been allowed for all the breathing movements to cease. So it is very important to know that images are exposed on expiration because the diaphragm in a superior position better visualizes the abdominal structures. So when you blow all your air out, and you can try that, it moves the muscles downwards and it flattens your abdomen flatter. Okay, since your back is on the table, it's the closest to the image receptor. We are trying to bring as many organs in line and flatten them down to the image receptor as possible. All right. So remember, expiration. This is to prevent motion and to push the abdominal organs towards the image receptor. I like to tell patients to imagine blowing out the cakes on a birthday candle. And little kids love this too. You just take in a deep breath, blow out the candles, blow, 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 and you hit that exposure switch. All right. So moving on. Now, markers. Where do we put markers? The correctly placed left and right markers corresponding to the appropriate side of the patient and upside indicator markers if you're doing the cubes. So it is not acceptable practice to indicate the side of the body after you expose. We've talked about this. It is not part of the permanent record. It can be changed post-processing. So that's why we state that you need to be using your markers. So the safest place to put your marker is in the bottom corner of the image receptor. And I'm going to tell you right now, the patients are on the table and you are putting the film into the bucky. The safest place to put your film or your marker is closest to you. And that would be the side of the patient, depending on where they are on the bed, just right there in the corner. And here's some pictures of where the corner is, because that's usually going to wind up in the greater trochanter or hip area and not in the way of any bowel. So collimation. We do not want the collimation to be too tight that it cuts off the skin borders. Um, for the radiographs of small patients, some side-to-side collimation is possible. This red line is pointing to the skin borders, but if we collimated all the way in, just to the skin borders, you would cut off, part of the iliac crest. It's just best, if you're not doing a pediatric patient, to just keep it open, because when they take in a deep breath and then blow it all the way out, your body still moves. All right. So let's just go over this x-ray real quick. That right there is the kidney. These lines right here are the psoas muscles. But you can see plainly here is the skin. Where you see the delineation of gray starts from black, that's where skin is. And like we have been saying, there are some patients that you can't collimate on. There are some patients that you may have to take the images landscape on the top and then landscape on the bottom. There are some patients you may have to shoot in quadrants. Just get it all on the images. So we do have to talk about shielding just a little bit. It is quote unquote recommended. However, it goes into the whole male shielding and female shielding, and it has to be here in place of the pubic symphysis and yada, yada, yada. Look, we know we should shield our patients. However, this usually obscures important patient information from the radiologist, and retaking of images is higher when you don't put the shields properly. So unless it's a pediatric patient, I generally don't recommend doing shields on plain abdomen films, because it would obscure whatever we're trying to look at in the lower pelvis. Okay, let's go. And I believe that is it. So just remember breathing instructions and collimation, and remove all the radiopaque items. So that's the end for mini session number 4, and everything should be on Canvas now for you to go and complete. Thank you much.